Welcome to the eClinicalWorks podcast. I'm Adam Siladi, and today we're here with Dr. Troy Carlson, family physician and owner of Family Tree Medical Associates in Hastings, Michigan, to talk with him about how he's been using eClinicalWorks and the patient-centered medical home model to rethink how he's been delivering care to his patients. Dr. Carlson, thanks for
It's great to be here
today. So your practice, Family Tree Medical Associates, is not your first or only venture. Tell us a little bit about how we got here today.
Well, Family Tree started in 1999 with myself and another physician, and through the last since 1999, Dr. Garber and myself, was the other physician that's working here in the practice, kind of came together and said, hey, we want to do primary care in Hastings, Michigan. And so with that, we started this practice with a couple nurse practitioners at that time, and basically has grown the practice over the years that we've been here up and through this year in 2016. There was a transition in 2012 where Dr. Garber took another opportunity to practice in a different location. And so with that change, I became a solo practitioner with a nurse practitioner here in the practice. And so that was quite a change and an adjustment. But the evolution of Family Tree, I think there are a couple major points. In 2006, we went to something called patient-centered care, which is a precursor, I think, to patient-centered medical home, which we'll talk about here, I'm sure, in a few minutes. But that was kind of a mindset change that the practice underwent to really understand and putting the patient at the center of care. And then with that, the next, I think, major change that occurred was in 2007 when we adopted eClinicalWorks as our patient tool to help us do what now is population management. So those are big things, I think, in terms of Family Tree and its progress, and really has put us into a different mindset and a different course through those things that transpired.
So you've been a patient-centered medical home for a long time, longer than you even had eClinicalWorks, it sounds. What have you learned by going through that medical home process?
Well, I think patient-centered medical home at its heart is really about putting the patient at the center. And a lot of times I think healthcare in our training and our education, a lot of times it's focused on the clinician and their expertise and their understanding. And the reality is without patients and our ability to understand it from their perspective, we're going to miss a lot of things. And so I think that mindset of taking and looking at patients from their perspective, certainly you have to be technically sound in your understanding of disease and illness and health prevention. But more importantly, for us to really start to relate to patients is when we put them at the center of care. And so I think that's really the cornerstone of patient-centered medical home. And our official designation of a patient-centered medical home came from Blue Cross Blue Shield of Michigan in 2009, and then we were NCQA accredited level 3 patient-centered medical home in 2010, and have maintained that status throughout these 7 years that we've been officially a patient-centered medical home.
I usually tell the providers that I work with that PCMH is more like going to the gym and less like doing your taxes.
Yeah, I think that's a fair analogy.
So you mentioned in another conversation that we had that part of your EMR selection was the criteria was that it needed to have a strong registry.
Absolutely.
Can you talk about how eClinicalWorks has been able to fulfill that requirements and help you determine what you need to do in order to meet your unique approach to care?
Yeah, I would say that has been one of the paramount things for our success, is the ability to know and understand who you're caring for each and every day. And so from the inception through the extensive process that we went through prior to the selection of ECW in June of 2007, was to recognize and know, who is it that we're caring for and what is it that they have, what medications are they on, what is our disease burden here in the practice, and how do we proactively care for that. And as a physician, I was most frustrated about the things happening to us a lot of the time. That especially as a family physician, I'm not an emergency doc because I don't like that feeling. I like to be proactive in the care that I'm delivering. And so when you have a patient registry, you see the patient and you have the ability to care for them even when they're not present. And that's the thing that I think most people sometimes forget about, is that we're caring for people even when they're not here and it's not their visit. Whereas in a paper world, it was just that patient became alive when it was their time in their day of the visit. And then they didn't go away, but they were still there on the shelf. But who were they and what were they about and what was going on with them was more of a mystery. Not that patients and doctors couldn't remember, but when we put that to the test, we're not always the greatest in that. So having a patient registry that was real and that was real time, that really allowed for us to then look at who we are as a practice and what it is that we wanted to do.
Well, you mentioned that concept of caring for the patient when they're not here.
Right.
What are some defining aspects of that concept that you would use to explain it to somebody who maybe doesn't grasp it right away?
Well, the caring for people when they're not here is that, and this is a hard one, I think, in healthcare to wrap sometimes in patients to wrap their mind around, as well as sometimes insurances, that this is a relational pursuit and people have things that are not going to be fixed in a day, and especially as a primary care physician, this is a longitudinal experience based on a relationship, and that's predicated on trust. And so when people share things with us that we're not going to be able to give them a pill or tell them to go someplace and immediately fix that. And so, we have, I think this longitudinal experience and about caring for people is interrelated to, say, our care managers or getting a prior authorization on behalf of a patient or trying to get a lab test or a radiology test that right now the insurance is pushing back on. And so we have to go the extra mile or to go and talk to a specialist. And instead of waiting 6 or 8 weeks to see the patient, we make a phone call, either the care manager or us as providers do, to say, hey, this is of great concern to us and we want to see this person sooner rather than later. And these are the care pieces that are taking place as examples of care that's happening, not just in real time or at the time of the visit. It doesn't stop. And then, all of where we're at in healthcare in terms of monitoring is that, if you're an uncontrolled diabetic and you come in and your A1C is 10, that's going to require a lot of time, energy, and effort by coordinating with our nutrition people at the hospital, our dietitians. These are the types of individuals that need to get involved in this patient care. We don't have all these resources right here in our office, but our job as a patient-centered medical home is to coordinate that care so that patient gets a touch from the people that's important in getting their health care corrected or straightened out.
Well, it certainly sounds like a lot of activities are going on, and
Absolutely.
I think that brings up the notion that a lot of these programs, recognition, adoption, what have you, have a reputation for being a burden, an extra burden on the practice, and that they're putting more barriers and more requirements between a provider and their patients. Can you talk a little bit about maybe what you've done to rethink the way that things operate to make those requirements actually work for you?
Yeah. I think it's a real piece. I think physicians all across the country are lamenting about things being put upon them and technology advancements and adoption and those kinds of sort of things. But I think, if we just ask qualitatively, why is this happening, is that, when I think about this more from a philosophical standpoint, is that, a lot of us are paying a lot of money to see and get health care. And what is the value of that? And I think now that we're trying to quantify that, and because it is so expensive, it's a precious, I'll use the word commodity, but it's not even a commodity. It's just a precious relationship that needs to be really taken care of.
Thinking about all these PCMH requirements, how do you then manage the things that you do have control over, like your schedule, for example?
For us at Family Tree, is we really like to use the tool ECW for that, because again, when you take the time to put in the details of all the things that are necessary to see a patient, including their past medical history, and with that, we're able to understand the disease burden of our chronic patients who have diabetes, hypertension, high cholesterol, the ages of our patients, and what are their preventative health care guidelines for those ages. So for us, it's almost a statistical question to answer, which is when you understand and know what your disease burden is, and you know what your requirements are to see those patients, there are amount of patient visits that you're needed to deliver to be able to meet your patients. And so for Family Tree, which is just under 3,000 patients, we're able to recognize, knowing the days of the week that we work, and what our schedule looks like, how many visits should be preventative, how many visits should be chronic visits, and how many visits, being a patient-centered medical home, about a third of those need to be open for open access. And so what we are able to do is to see where we're at as a practice, where our deficiencies might be in terms of provider volume on those particular days, as well as to make sure that when we template out in a perfect world what that might look like, is that are we missing anything? So it really brings it down to focus to really be able to see, is our practice going to be able to meet the need of our patients? And then if there are deficits, and then I think that would be the time for a practice to say is, hey, we do need to bring in another nurse practitioner or physician to be able to help that need, or make qualitative judgments as to whether you're growing your practice or you're shrinking your practice to make sure you're caring for the people that are within your practice.
So you're saying by using this formula or calculation, whatever you want to call it, you're able to know ahead of time whether you're looking at 10, 12-hour days or whether you're right in the sweet spot of where you want to be with the hours that you want to work.
Yeah, and I think that's, as an independent practitioner, that is an advantage. I mean, you want to meet your patient's needs, and physicians sometimes have a tendency to overdo it in terms of their workload related to their relationships with their patients. But I think this is a practical way of looking at that, and that you can really look at your life, and you can look at your family, as well as how you're caring for your family within the practice of family medicine, internal medicine, primary care, and then really try to quantify where are you at, and answer those questions to really make it work for you and your practice.
Well, we're going to continue our discussion after we take a quick break. Stick with us.
It's moments like this that make me go another year. 4,500 attendees, 49 states, 5 countries for the first time. 450 eClinicalWorks engineers, support staff, trainers, product specialists. Mingle with them, ask them questions. 50 exhibitors, hands-on training. It's just full. The most exciting product showcase, 16 plus demonstrations for you. We will blow you away.
Don't miss this extraordinary 3-day event, which we'll cap off with an amazing night of dancing, music, entertainment, networking, and much more. Come join us for our 2016 National Conference in sunny Florida at the Orlando World Center Marriott from October 21st through the 24th. For more information and to register today, visit us at specialevents.eClinicalWorks.com.
Welcome back. I'm Adam Siladi, and we're speaking with Dr. Troy Carlson here at Family Tree Medical Associates in Hastings, Michigan. So we were speaking before about your experiences with patient-centered medical home and the impact that it's had on your practice. Now, care planning is a major component of patient-centered medical home, and it seems to play a big role in the care that you provide your patients. But it's obviously included for a reason, right? It's not a given that it's happening. So what would you say is missing from traditional care planning that is not currently being addressed? Or are we even on the same page when we say care planning?
I think, Adam, what you're maybe alluding to is maybe we're talking about care management, which is the incorporation of other providers besides physicians or nurse practitioners in the office. Some offices have done this for quite some time, but in primary care, and that's something that we're involved with here in Michigan, is the Michigan Primary Care Transformation Project, which is the inclusion of care managers at the point of care. Care managers, to me, in their inclusion, have allowed for us to go to the next level of care for patients. And what I mean by that is this, is that, in our patient visits, patient comes in with a disease or condition, we review labs, we review medications, we talk about what those, where those things are at, we listen to the patient, their concerns, and we try to address and make the patient look good in terms of a blood pressure. Hopefully they feel good in terms of what they're feeling, although a lot of times that's not something that we can always readily take care of. Even though sometimes what I sometimes like to tell patients is you're euboxic. In other words, all your labs line up really nicely and there doesn't appear to be anything wrong with regard to that part of medicine. But there are other things that are going on with patients that really, even though their labs or their medications are doing fine, that somehow they're hurting. And so a lot of times, especially as a primary care physician, we get to learn about those things that are troubling patients, which can certainly at a later time impact their care.
You sound like you're addressing the 2 points of the triple aim, which we hear a lot about, right? Improving care and as a result then improving population health. But there's that third part of that triple aim, which is reducing costs.
Right.
And a lot of focus recently has been given to the rising cost of prescription drugs, generic and otherwise. So what impact is this care management supposed to have on overall healthcare spending?
Well, care management is addressing, I think, at least the way we're doing it here at Family Tree, is that it needs to be technically sound. So we need to be good on the sciences behind the disease conditions, but more importantly, we have to be great with the patient and understanding where they're coming from. And so it's an opportunity for us to kind of dig into that piece of patient care that otherwise wasn't afforded. The social context with which we live our lives accounts for 50% of our healthcare spend.
So certainly it sounds like there's a big impact that this could have. You're saying that there's estimates that it's maybe as much as 50% of all the spending is related to the choices that people make,
yeah,
or
absolutely.
the things that they're able to access as a result of their social circumstances. Given all that you've been able to accomplish, which tools in eClinicalWorks have made the biggest impact for you?
I would say for us, it's the ability to population manage our patients, which make the biggest impact on a regular, weekly or day-to-day or monthly basis, depending on the reports that we run. The patient registry is very important, and to be able to collate information. I really appreciate the ability to individualize the care that you're giving. So eClinical allows for structured data to be gleaned. So if you're doing something uniquely as a practice and you want to know and understand what it is, you can set it up such that you can see how you're doing from your own internal report carding, if you will, as to that. But I would say overall the patient registry and your ability to know and understand your disease burden and then proactively manage your patients through population management would be the biggest tool within ECW that we use and that has been helpful to us in our patient-centered medical home.
So if you're tracking certain patients, certain populations of patients, whether it's a disease-specific tracking or whether it's a outside program-specific tracking, how do you make that more visible in eClinicalWorks?
eClinical has a function, many functions, but one in particular that we use since we're involved in this national research. It's the highlighting of a subset of patients, and we used to use that tool to identify diabetics, which have, from a care management standpoint, more responsibility to and making sure in terms of coordination. Now we use that tool to highlight our Michigan primary care transformation patients, which are about half our practice, but it helps for us to identify and sends a message to the rest of the staff as we work as a team to make sure and identify that these people have special, potentially unique needs or responsibilities that go along with that with regard to us being in this research study.
So you're able to enable them in the registry, and then they're highlighted on your schedule so you can see them at a glance.
Absolutely. Yep.
A lot of stuff to consider, obviously, that we've talked about, but there's always more, right? We always know that there's always more. Right. What do you think independent physicians might not see coming in the next few years?
Well, if I know independent physicians, and being one I think I do, most of them, unfortunately, have a hard time staying up with the things going out externally to them because they're so busy taking care of their patients. But to answer your question, this transition to value-based care is going to be a huge one, and it's a mindset change.
Well, Dr. Carlson, we've certainly appreciated having you as a companion with eClinicalWorks along this journey of yours and of ours as well. We hope to keep seeing more of you and keep working with you in the future.
Thank you.
If you liked what you saw in this episode of the eClinicalWorks podcast, you can check out our other episodes on our YouTube page or download it on iTunes. Thanks for watching. For the eClinicalWorks podcast, I'm Adam Siladi.
This broadcast and its contents are the sole property of eClinicalWorks and are protected by federal law and international treaties. You are strictly prohibited from making a copy of, modification of, or form of rebroadcasting or re-encoding this broadcast without prior written permission from eClinicalWorks Public Relations, except as may be permitted by law. This broadcast is provided for informational purposes only. It is intended as a personal, non-commercial use. Product specifications are subject to change without notice. Please contact eClinicalWorks Public Relations with any questions. eClinicalWorks V10 EHR is ONC HIT 2014 edition certified as a complete EHR. eClinicalWorks V10 CC 2014 955447-1.